welcome to Conflicts Between Law and Public Trust in the Name of Public Health, COVID Experiences from Around the World. I'm Sophia Greskin, and I'm Director of the USC Institute on Inequalities and Global Health. And on behalf also of the USC Law and Global Health Collaboration and the USC Community Health Equity Solutions, it's my great pleasure to welcome you to this incredibly exciting event. For those of you that don't know, as part of the Institute's vision and our commitment to a more just and healthy world, traditionally we bring global health leaders to USC to share their experience and to engage with students and faculty around common themes of interest, and all with a particular focus on understanding and addressing health inequalities here in Los Angeles and around the world. Given COVID and the virtual nature of these things these days, more and more we're operating across several time zones in ways that can allow events like this to occur. So the fact that we can do something like this, I guess, is a positive amongst all else. And between the panelists and the audience, we have folks from every region of the world in this discussion, which is in and of itself amazing and can hopefully lead to a rich discussion and sharing of experience. I thought I'd begin by actually saying something quickly about the genesis of this event. With all that's going on to get the virus under control in all of our countries, law has been really critical for this effort, whether to ensure people have access to testing and eventually to the vaccine, but also to enforce stay-at-home orders, to mandate social distancing, etc. And with the law, we have seen the use of public health directives to enforce these measures, but also the use of police power and criminal law. And in all cases, we've got to query, given the rationale for these measures is to address the virus, how effective is the measure being imposed if you measure it in actual public health terms? We've also seen the way in which the virus is being allowed to allow politics to be played out. Laws justified in the name of COVID that have been really harmful, way beyond an acceptable public health rationale. Whether it's the explicit and deliberate targeting of certain groups of people that's justified in the name of COVID, whether and how the law is written or how it's applied, the shutting down of essential health services, such as sexual and reproductive health or abortion services, even if provided for in the law because they're deemed not essential, or the effects on our communities and the impacts on real people's lives of people unable to pay their hospital bills or their rent because they were sick or they're out of work. And in all of these, there have been responses from communities and from lawyers in addressing these laws and their discriminatory impacts. And each of our speakers today is doing amazing work to address these issues. And that's what brings us together today to talk and to think through the global, the national, and the local responses in all of our countries, and what we need to be looking at and thinking about and addressing if we're going to get the virus under control and to minimize the incredible toll this moment in time is taking on people's lives. Let me start by quickly introducing each of our panelists. Mandeep Dhaliwal is Director of the United Nations Development Program's HIV Health and Development Group. Gerson Soto is a supervising attorney with Neighborhood Legal Services of Los Angeles County. And Alan Maleche is the executive director of the Kenya Legal and Ethical Issues Network on HIV and AIDS. And so to situate this discussion, I'm going to start by asking each of our panelists to tell us a little bit about how they work in this area, before then giving them each 15 minutes to present and give some detail, and then open it up to Q&A. So allow me, I guess, to pose the first question, which is, what is the bulk of the work that you do at the intersection of COVID and the law? Can you introduce that, please? And let me start with you, Mandeep.
Thank you, Sophia, and thank you, colleagues. And it's delightful to be here because throughout my career, I've often found that law is neglected and often overlooked determinant of health. So I think it's wonderful to be able to talk about the various ways that law and public health interact, and particularly in pandemics. So UNDP is the United Nations Development Program. We are present in 170 countries. And through our health practice, working also with closely with our governance, crisis response, poverty, inequality reduction experts across the organization, we look at the role of the law in HIV and health. We've done a lot of work on collating data and evidence, on making that available, increasing the transparency of laws so that communities, public health officials are aware of the law. And I was particularly taken by the title of the webinar because I think there's a huge and a really important discussion about how law can be used to increase public and community trust, which is really important. And I think there will be many lessons from the COVID response. So community trust, community participation, using, making evidence and information on laws available so that we can engage communities, those who are affected by laws, in shaping and implementing laws. That's sort of the modus operandi of the work that UNDP does, bringing civil society and community to the table with lawmakers to review, revise, implement laws, and focusing very much also on the issues of accountability by making information about laws available. And I'll get into a little more of the specifics around that. But a lot of this work has been based on work that we've done in the area of HIV and HIV in the law, and looking at legal, rights-based, evidence-based analysis of HIV-related laws across the world, and working with multiple countries to follow up and to improve the legal environments for effective HIV responses. And many of the lessons from that, which I'll talk about later on, are relevant in one way or another to how we can use the law as a more positive force in responses to COVID. And that can be, and Sophia, you mentioned some of the issues, emergency declarations, designation of essential services, the use of digital technologies, which I'm really interested in, around contact tracing, surveillance, and how this plays out on groups that are already vulnerable, marginalized, how this plays out in the context of gender inequality. So really from a development perspective, how the law can be used in epidemic and pandemic response.
Thank you. I super appreciate that. Alan, would you introduce yourself and a bit about the work that you do in this area?
Thanks for having me here today, and really honored to be joining the conversation with our good friends and colleagues. I just want to start by saying that I work for KELIN. KELIN is a non-governmental based organization based in Nairobi, Kenya, that focuses on health and human rights. And we largely do most of the things Mandip does, but not at the scale at which UNDP does it. That's why we are great partners with the UNDP family in terms of looking at the intersection of law and health. And we primarily began as an organization focusing on HIV and the law, and the legal and ethical issues that arise within the intersection when you're providing HIV interventions and dealing with the law. But we've grown and expanded towards looking at issues of health and human rights, particularly areas such as sexual reproductive health, areas around health governance and accountability, still building up on our work on HIV, TB, and other non-communicable diseases, while also looking at the intersection around women, land, and property rights and the connection towards women having healthier lives by having access to their lives. In terms of COVID, naturally, given that it is a pandemic context in the health sector, we have then had to work within the intersection around the laws, the policies, the interventions, the outright human rights violations that have happened. And later on, when we delve into our presentation, we'll be able to speak about some of the intersections of the work that we've done. We do also rely a lot on litigation, going to court to secure people's rights, to also help the courts in developing jurisprudence around important judicial decisions on these issues, and we'll also speak about more of the cases. So pleased to be here to have the conversation, and definitely looking to learn from colleagues and others around how best can we ensure that we use the law in a way that promotes human rights, but also good public health approaches.
Thank you. Thank you. Alan Gerson, please.
Hi, good morning or good afternoon, good evening, wherever you are. So it's a pleasure to be with you today and to get to meet great colleagues here as well. Neighborhood Legal Services of Los Angeles County is a nonprofit law firm here in Los Angeles, and we work to engage throughout the community and really focus on our communities in poverty and helping them really ameliorate a lot of the effects that are happening, not only through COVID, but through other crises, through inequality and so many barriers that our patients face. Today, my primary focus is going to be around medical legal community partnerships, and I supervise our medical legal community partnership work. For those of you that aren't familiar, and I'll speak more to this during my presentation, MLCPs are ways that healthcare providers and lawyers and law firms can work together to really impact factors that affect the social determinants and really improve patient health. And our goal throughout all these initiatives is to be able to partner and engage with the clinical teams in such a way, such a very intimate way that doesn't always occur. There's sometimes a natural tension between our healthcare and legal fields because we often just see each other in an adversarial context, in a med-mal case or something like that. But we've really developed some truly, strong relationships through these projects. And through the pandemic, I think we've been uniquely situated to see both from both perspectives, from the perspective of our clients and the true barriers they face in accessing very essential services and supportive benefits that are available to them, the challenges from the various agencies, the challenges due to various policies that were implemented in an effort to get ahead of the pandemic. And then at the same time, seeing our healthcare partners both early on as they figure out how to deal with the pandemic, and then now that we're almost a year in, how they're responding, how their workflows are changing, and how we're really leveraging this partnership to ensure that patients that are coming through their doors are able to engage with their clinical care in a meaningful way, and also able to maintain stability in whatever that context might mean now, both in terms of housing, healthcare access, safety, and a lot of other issues. So pleasure to be with all of today, and I'm definitely eager to learn from my colleagues as well.
Fantastic. And really, everybody, you see what a wonderful panel we have, right? I mean, just amazingly different introductions and approaches to dealing with these issues. Alan, is it okay if we start with you, if you would start with your presentation now?
I'll start off with building up on the introduction that I brought on board. We've already spoken about Kelin. I'll speak briefly around what are the human rights concerns we witnessed in the COVID-19 response in Kenya, what approaches did Kelin take, and sort of give some quick reflections around how we're moving forward with this because COVID is still with us. I think I've already talked about what Kelin does and how we're able to operate, and for those who need more information, it's available at the end of the slides. I'll make it available. But I want to start by mentioning the fact that most of the human rights concerns with regards to the COVID-19 response were highly medicalized in the context of Kenya, but also in other countries where everyone took a medical approach towards addressing the issue. And in so doing, there was limited community voices and participation, particularly with the setup of the government task forces that were supposed to be able to provide guidance. And naturally, then we had to see them developing laws, policies that were more restrictive and punitive in a way of trying to ensure that public health measures were being enforced, be it wearing a mask, be it maintaining social distance. And the highly medicalized approach combined with limited community voices or participation by the general public in formulating some of these policies and practices and focusing more on the punitive aspect led to increased stigma and discrimination in the terms of how we were dealing with some of the people in the country who were some of the first ones to test positive for COVID, and how maybe we may not have maintained proper confidentiality or painted them in a picture as people who had not taken sufficient precautions, thus putting others at risk. With using a criminalized approach, then there was also a perspective of increased human rights violations in the terms of which law enforcement, particularly the police officers, would enforce some of the laws and regulations that had been hurriedly passed without proper consultation, which meant there was more violence, there was more harm, and there was less appreciation of the public health measures because of the approach that was taken. This juxtaposed as against to a situation where limited access to justice in terms of courts were not fully functioning. There was no physical court. Most court was happening online. Most people were restricted within their homes with limited movement. And so access to justice was greatly limited. And so that was really some of the concerns and layers that we saw at the beginning of the pandemic. But as things eased down, some of this improved and some of them continued to get worse. So what are some of the examples that we see that show that there was a conflict or exposes a conflict between what the law is trying to do, what the public health outcome is supposed to be, and how that is eroding public trust? So some of the measures that were taken into place were the passing of regulations that put into place a dusk to dawn curfew. At the beginning, it was from 7 p.m. To 6 a.m. And I think the challenges that came with that was around one, the fact that the police would actually be right out there at 6:59 on the dot, trying to ensure that anyone who was not into their houses by 7 p.m. would then face the wrath of the law. And the first days actually saw a lot of violence being meted on those who may not, for one or two reasons, may have gotten home on time in order to beat the curfew at 7 p.m. I think also with that declaration of the curfew, without thinking through, then saw a challenge in terms of what happened if I was a woman and I was pregnant and I needed to rush to hospital? What happened if my child fell down the stairs and I needed to go? Yet I've been told between 7 p.m. and 6 a.m., stay at your house. If you come out, you're likely to face arrest. What then happens to people that we work with, especially sex workers or others who need to operate at certain times, and that then becomes a challenge? And so the enforcement of the curfew from dusk to dawn actually provided an avenue where most human rights violations were happening, and the manner in which the police then enforced this without the Ministry of Health coming in to challenge and say, this is not the way to go, then led to people being more exposed to the COVID virus. So again, though the regulations did talk about the fact that one would be imposed a fine if they were found out after curfew, you'd find that the practice that was adopted by law enforcement officers was to actually, those who were found out after the curfew were actually taken to quarantine centers, which did not make sense. That if I was leaving my office to go home to beat the curfew, and I can't get public transport to get home in time, and I'm found there, they end up taking me to a quarantine center. If they find me not wearing a mask, I'm then taken to a quarantine center, which defeats the whole aspect of public health, because I, as Alan at that time, have not exposed myself to COVID, but because I've breached curfew, I find myself in a quarantine center without going through a judicial process and without going through any process that would help justify whether I was right or wrong. And so that was the adoptive measure that was taken, that then goes contrary to the public health measures that you're trying to take in order to provide people safe. There are restrictions on movement from one county to another, or for those who are in the US, from one state to another. So there are restrictions around who could move in, who could move out. And that also posed a challenge in terms of rural population accessing some of the urban related facilities for health. And that became quite a challenge. I think I've already talked about the increased police brutality. We've got fatal cases of people who've been shot dead for not wearing masks. We've got cases of healthcare workers who have actually been arrested by police when they're trying to move from one county to another in terms of looking for a job or to try and enforce their duties. And so there's been a lot of police brutality and extortion that has come with the rollout of the curfew rules and not wearing masks. And I think some of the ridiculousness in the regulations that were passed without thinking through, including restricting the number of people in personal and public vehicles. Public vehicles may make sense, but in terms of personal vehicles, if you say a family that has 5 people should not ride in a car that is exceeding half the capacity, you then mean that only 3 of the family members can actually ride in that car if they are going to school, if they are going to work, if they are going for a medical aspect. And that then defeats the purpose of saying you're all in one house, you probably have all exposed each other. So what difference does it make if you only have one car and only 3 of you can get into it, or you run the risk of being arrested? And on all this other hand, even for the public transport, no government measures were put in place to try and increase the number of public vehicles, yet you're saying reduce the number of people coming through. So those are just some of the few examples. And I think the skewed enforcement of the laws, on one hand, you're told to practice social distancing by the government, but on one hand, the same government is not taking legal action against people who are carrying out political rallies and other aspects that don't take into account the aspects of social distancing. So what is our approach as Kelin in terms of trying to address this? For us as an organization that believes using a rights-based approach where there are principles of accountability, transparency, and non-discrimination, our beginning point was to give a directive and an advisory working with other partners to the various government agencies to say, and look, we have a pandemic, this is what is happening, and for us to be able to thrive from the pandemic, to be able to ensure that our citizens are safer, people adopt public health measures, you need to adopt the following measures in your approach in terms of dealing with it. We have done it in the HIV response, we are doing it in the TB response, it has been done with the Ebola response, so there's a chance to do it with the pandemic relating to COVID. And so we then issued this advisory where we sought to tell the government and other stakeholders to say, this is the approach you should adopt if you want to win this particular pandemic. And of course, that fell on deaf ears, as we shall see later. And we also went into partnerships with healthcare workers, various sectors, to take down surveys to document the level of preparedness. Did they have enough protective equipment? Had enough training been done? Did they have insurance? What was to be done if one of them got infected? And so we did all these kinds of surveys in terms of taking forward. We partnered with various organizations to create hotlines where people would be able to call us, SMS us, text us, email us where they were facing challenges in quarantine centers, where they had been arrested arbitrarily, and eventually that led to us mounting a number of cases in public interest litigation around rights to information, around challenging quarantine, around challenging detaining of people in healthcare facilities for them failing to pay for COVID treatment. We also engaged with the laws and regulations that were being developed by submitting various memorandum to legislative bodies to try and say the laws and regulations being developed need to take into account human rights principles. Let's not take a punitive approach. Let's not use discriminative or stigmatizing language. So these are some of the interventions we did with some of our partners. This is just an example of some of the letters that went out and the partnership that we drew together between different people from the health sector, from outside the health sector, because COVID brought us all together. So these are just examples of open letters that we did, and they're available on the Kelin website. As I said, we did institute a few cases around issues of quarantine. We did have toll-free numbers, and those are some of them which are still existing and working with different partners across the consortium of access to justice, not only those working on health issues, but also those working on governance, including those who are working on issues of transparency and accountability. So we have about 4 cases currently pending before the court, trying to get jurisprudence around when you're enforcing quarantine, what are the human rights principles you need to take into account, when people are requesting for information during a pandemic, what should be expected of government, what are the standards in place, and also during a pandemic, who then bears the cost of treating people, especially in a country where funding has been provided. So these are some of the memorandums we sent to the Senate, to our Parliament, to try and raise issues around the dangers of criminalizing the response. And eventually where we are at now is that some of the engagement was fruitful, where Parliament did pose questions, did set up committees to investigate some of the transparency and accountability concern. But by and large, we saw a lot of resistance from the Ministry of Health in terms of them working the way they have already decided to work, and any letters, any request of information was seen as a by the way. We unfortunately have not seen a quick turnaround in terms of the decision on cases, and so some of the cases may have been decided much faster, but because of the delay from the response from government officials, we have seen cases delaying and almost now leading to about 9 or so months without making any steady progress in some of the cases. So as I conclude, I want to say that we have tried to put in place many efforts, but the challenge remains the fact that the political will on the side of the executive to listen to other voices, to be able to be adaptive to measures given by other people are also quite problematic. The ability of the judiciary to move things forward quickly also in certain matters is also quite problematic in terms of getting jurisprudence that would guide the government on what needs to be able to happen. The inability of the executive to call out certain practices by the police and law enforcement has then made it extremely problematic. And I think it remains inevitable that human rights and human rights principles should also be at the center of the approach, because if you're looking from a public health perspective, you're seeking to encourage people to do good behavior. You want them to understand why it's important to wash hands, why it's important to wear a mask, why it's important to maintain social distance, why it's important to ensure that you seek treatment when you show certain signs and symptoms. You're not going to succeed in doing so by using threats, by using force, but rather by using persuasion and common sense in terms of explaining to people why these measures are important for them and why these measures are important. I just want to also mention that even with the emphasis on vaccine rolls out, we shouldn't forget about the role of communities, and we shouldn't forget about the basics that we need to test, we need to treat, we need to isolate if we want to be able to win the fight against COVID. Thank you, and I hope I stayed within the time.
More than. Thank you. Thank you so much. And, we're just also grateful for your work. I thank you also for raising the issues that are relevant to Kenya, that are relevant to the African continent, and are relevant to all of our countries. And so thank you. Thank you, Alan, for that. That's super helpful. Gerson, please, if you would.
So as I mentioned initially, my goal with today's presentation is looking at how as a legal services organization providing direct client services on the ground, how we're working to ameliorate the effect of COVID-19 on our communities that are already in poverty. And I'll start, for those of you that maybe aren't familiar with some of the more specifics around Los Angeles, we are a population of roughly 10 million people. We cover roughly 4,700 square miles, and it's a very diverse county in different ways. Diverse geographically, very urban city center, suburban cities. There's forests, there's deserts, beach towns. It's very, very diverse, and also diverse in the more conventional sense in terms of our racial and ethnic composition, primary language, wealth, education, immigration status, and other markers. And just like many other communities, we've definitely faced our fair share of challenges, going back as far as the struggles for racial equality and civil rights, weathering numerous disasters like drought, wildfires, earthquakes, and now COVID-19. And today, we've been really the hotbed for COVID-19 here in the U.S. We have so far 1.1 million COVID-19 cases throughout the county, 18,000 deaths, and so many new strains of the virus that are presenting each day and put us all at risk. And there's other statistics that aren't as clearly found, other changes and barriers that are not as clearly found within statistics. One, looking at countless families that have been impacted by the pandemic, whether it's the trauma of loss, whether it's the rise of intimate partner violence during quarantine, or even the educational and developmental impacts that our children are facing due to remote learning and sometimes doing that in suboptimal environments. So it's within this framework that organizations like ours are providing services, and we've been operating for over 50 years here in Los Angeles, and our services are built around 4 basic pillars of legal support for people living in poverty: housing, health, economic security and stability, and access to justice. And a little bit about us, we offer assistance to more than 150,000 low-income people each year through a variety of program offices, co-located centers within various courthouses, and a county network of medical legal community partnerships, which is the focus of my talk today. So going a little bit deeper into medical legal community partnerships, in a lot of the literature, you'll hear them addressed as medical legal partnerships. We've added the community piece in there, just really understanding the importance of community on so many different layers, both within our communities, within our clinical settings, within so many different variations of the word. And the goal behind MLCPs is to really integrate the expertise of healthcare, public health, legal professionals, and all the staff to address and prevent all the health harming social needs and legal needs that our patients, our providers, and populations are facing. When we partner together in this way, we're really able to transform the space and transform the healthcare system's response to these social factors that contribute to poor health, and often referred to as the social determinants of health. And so a few key aspects of this model. One is a real focus on prevention and upstream interventions. So just as through the medical side, when preventative screening is so important, and when you have a screening early on, you can potentially detect some cancers like ahead of time and have a really great chance of combating that cancer. Just same with legal issues and a lot of the barriers that we see, identifying, for example, a potential housing issue early on when a patient first receives a notice, or when a patient is first having a dispute with their landlord, helps us potentially prevent homelessness if that intervention happens early enough. In addition to prevention and these upstream interventions, we're working with our provider teams to empower them through education and training. And during the pandemic, that's really turned out to be so important and crucial. As many various supportive programs come into play, a lot of challenges have come through as well, and keeping our providers or social workers, community health workers, everyone appraised of those latest updates, of letting them know that patients have rights. And if a patient says, I'm having problems making ends meet, here are the 10 things that you should be screening for. Here are the clients you should be referring to us, really working with them and partnering with them there. A key piece to this is also just increasing access to justice, both within our communities and all our clients that are involved. Through that work, we not only look to resolve our clients' individual problems, but also strive to identify broader systemic and policy solutions that our communities face. And during the pandemic, as I mentioned, during my initial introduction, I think that MLCPs have really been uniquely poised to reach patients early on. And through one of our projects, that I'm going to focus on today, we partner with 4 other nonprofit law firms to deliver services throughout the County of Los Angeles to a number of county hospitals, regional health centers, and community clinics. Prior to stay-at-home orders, we were actually co-located at 9 different sites throughout the county, and we were embedded in the clinics and in their workflows, so that when a patient came in, they would talk to their doctor and then maybe go down the hall and talk to the lawyer, or maybe their nurse would come and talk to us and say, look, I have a patient that's dealing with this. What can we do? We even created a legal prescription pad that allowed providers to really identify these needs in a very accessible way. And patients are used to getting a prescription for their healthcare. Why not get something to alleviate their other barriers as well? But as the gravity of the pandemic became more apparent, we were ordered to stay home. So I think it was March 14th or so that we started our work from home. And especially in those early days, it's really vivid to me, in being on some of these conference calls and seeing the raw emotion and fears from our providers as they engaged with patients, and dealing with limited PPE or personal protective equipment, dealing with figuring out how to even engage COVID patients, not understanding the method of transmission as well. And we saw, I think understandably so, during those first months, saw a real dip in referrals. And that was a concern to us because we knew that patients had legal needs and that this is when they needed them the most. But understandably, our healthcare partners were so focused on dealing with the pandemic that working on some of these other issues was a challenge. So we ended up looking to how we could still engage with patients. So we used this time to focus on education within the system. We focused on social workers and CHW, community health workers, and others that were engaged with patients. And through these efforts, we were able to hopefully, I think, identify ways that they could screen for additional psychosocial issues. We created a webinar series, for example, that I think collectively probably trained around 700 or 800 providers, helping them understand areas like unemployment benefits, housing protections, healthcare benefits. We created informational materials and simple screening questions. There was 5 screening questions that we asked every social worker to engage with their patients each time, and those would all trigger referrals to us. And, I think a lot of us now, after a year of working from home, sometimes have Zoom and video call fatigue. But for us, I think at the time and now presented a really great opportunity to really allow us to participate in other meetings we might not always get to. So a lot of clinical meetings, case reviews, team huddles, we were there to hear the clinical discussion and also interject when there were patients that we thought could have legal interventions. And I think through all of these efforts, we saw that referral numbers started increasing into the summer of last year, which was great. Collectively in 2020, our collaborative saw over 3,000 legal cases, which represented almost 2,000 unique individuals. And the graph you see shows some of the more common legal barriers that were addressed and identified. And as the pandemic raged on, even though the number of referrals wasn't, up to what we thought it could be, the number of cases or the number of legal problems that people had did increase significantly. So at one point, it really was not uncommon to have one patient have maybe 4 or 5 legal concerns, even though they might have been referred for just one. So that was a really key piece. And our role has really been to help patients navigate through these various systems of support that were implemented to minimize the effects of the pandemic. So as an example, we're fortunate in that there were a lot of different supportive systems, opportunities for public benefits like unemployment benefits, food stamps, cash benefits, and others, housing stability benefits. And while these benefits had a no wrong door approach, it almost was as if there were too many doors and patients were overwhelmed and couldn't really engage with them. So a lot of what we did early on was trying to help them navigate through these problems. As these agencies themselves moved to remote work, that presented a lot of other issues with engaging their services with patients, particularly patients who had disabilities, who were non-English speakers, and how would they engage with these agencies and programs. So I think in a way to kind of share this information, I'm gonna focus on a few client stories that I think illustrate some of the barriers that we saw. And just so you know, I'm using pseudonyms for patient privacy, but these are all stories of patients that we saw during the pandemic. One that stands out to me the most, I think, out of all of them, just because of the patient's nature, was Maria. Maria came into our clinic. She was asking for help for temporary disability benefits. So she came into the clinic and was referred over to patient records because she had a form that she needed to have filled out. And we had actually just started at the clinic, so they sent her up to us. And we talked to her, and it turns out that she had actually applied for long-term disability benefits on her own, but she had been denied. She was in her 60s, she lived alone, and was having trouble affording rent because she couldn't work. She basically survived from the charity of her family and friends and loans. And we met with her right before the pandemic hit, so we actually saw her in person. And then the pandemic hit, and things got a lot worse for her. We were working with her and determined that, she actually was not eligible for disability benefits, for temporary disability benefits, because of her work history. She had not paid into that system. So we started exploring, her long-term disability, and she had mobility problems. She also had ongoing mental health problems that worsened as a result of the pandemic. So she was isolated from her family. She was at risk of homelessness. She was having to borrow money from everyone. All these pressures coming to her, making her depression, her anxiety far more unmanageable. And that's something that we've seen as a very common theme throughout, is the access to mental health services for a lot of our patients is a challenge. Particularly, patients who need to have that in-person connection, whether because they don't have a safe space to have it or whatever else, that is very hard to find. And patients like Maria, she truly felt hopeless, and it was, she was such a sweet person. It was really heartbreaking to see her in that state. So we worked with her and we helped her prepare an appeal, and we partnered with her doctors to prepare some letters of support on her behalf. And I think that's one of the great areas that medical legal partnerships can intervene with that partnership and engage with providers in that way. And within a few months, she actually got her benefits approved. She also got a surprise lump sum retroactive disability benefit for like 8 months. And now she had money that she could pay back all these people that she had borrowed money from. So her spirits were lifted so much, and she felt so, her mental health was so much more relieved knowing that she had stable housing and that she had some, actual stability in terms of her income. And, that's one case, but not all cases or not all interactions with a patient rise to the level of opening a case. sometimes it might be just us giving patients general information about, their housing rights, and maybe they have concerns about what my landlord might do in the future if I can't afford my rent, things like that, or educating them about the different housing protections that exist. But in other cases, we do have to get more involved. And there was a case, patient Laura, and Laura lived with her mother in subsidized housing for seniors. And so Laura's mom grew older, she needed extra help, and Laura moved in as a caregiver about 10 years before. And Laura's mom passed away due to COVID. And now Laura was her caregiver, and she wasn't a senior though, so she actually wasn't eligible to remain housed at this location. And the housing managers told her that she had 7 days to move out. So she had just lost her mom, she lost her source of income, she had no family. She was also exposed to COVID and didn't know whether she was COVID positive, and now she needed to move out within a few days. So we intervened. I think we fortunately had some strong legal arguments to extend the stay, and we were able to extend her stay by another month of rent-free time, during which we worked with her clinical social work team and connected her to housing. So then she was housed. It turns out that she was eligible for unemployment benefits. We got her that. And then she this whole time had not had health insurance at all. So she was going to clinics and paying out of pocket. So we were able to help her navigate, that benefit as well. But her program, and she had a positive outcome, and she's in good shape now. But her problem really highlighted, I think, a common barrier that we see is that through the pandemic, a lot of the social services that people need to access are closed for in-person help and primarily offer telephonic or electronic assistance. And not all of our patients are tech savvy and can actually engage in that way. And they need additional support. So we actually, as part of our work, do engage with leadership from these various state and county-wide agencies to identify these problems, identify solutions. As an example, there was a statewide moratorium on any negative actions on Medicaid, which is our subsidized healthcare program. So this meant that patients could continue to access healthcare benefits and still to this day can, even if they can't come into an office to provide renewal paperwork. But other benefits like CalWorks, CalFresh, monetary benefits don't have that same action. So we're still working on those issues as well. And one other major problem that remains a concern is housing. So a lot of our patients live in multi-generational households with higher patient densities and resident densities, putting everyone at risk, especially those that are at higher risk categories. A lot of our supportive housing programs are now overwhelmed, and there really isn't enough affordable housing to have people safely housed. So there's a lot of great work that's happening, a lot of statewide advocacy to promote additional laws that would protect our patients, including those that can't afford to pay their rent and others, but there's still a lot of work to do. Very quickly, some of the other issues we're seeing relate to agencies that are themselves overwhelmed. EDD, the Employment Development Department, who manages unemployment benefits and state disability, is a prime example of that. Patients having to wait hours on hold, patients having to call days on end until they can finally reach someone. So we're having problems that would have been easily resolved before through a phone call. Now patients are going without benefits, or worse, like some of our patients are actually being charged with fraud because they just don't know what to do. So, ultimately, I think MLCPs are uniquely situated to engage with healthcare workers and identify, barriers throughout the pandemic. I think our role and relationships within these systems not only helps us ensure that the clinical teams are screening and are doing what they need to do, but also looking for other psychosocial barriers that put patients at risk. And I'm really happy that we're able to engage with them in this way, and that they've really been open to a lasting relationship with us. So yeah, that's it for me.
Thank you. And your work is so important to those of us in Los Angeles, right? And so I'm just incredibly grateful for the work that you do, but I also think that the issues that you raise are issues everywhere. And so I really appreciate kind of the way that you frame that, and also the way you personalize those stories for us. Thank you so much. Mandeep, the floor is yours.
Thank you so much. And what an honor it is to follow these two extraordinary presentations, really, of such important work on the ground. And I hope that I'm going to follow up with you, Gerson. I have so many questions and things to share based on work I used to do in India many years ago. So I want to step back a little bit and talk about the intersection of the epidemic response and the law. So from what we've seen at UNDP, we've seen countries responded to the COVID pandemic with a flurry of different laws and regulations. These covered everything from declarations of states of emergency and limitation of rights, including freedom of movement, criminalization of potential exposure and transmission, procurement of PPE or other health commodities, designation of essential workers or essential services, and the use of digital technologies for contact tracing and surveillance. In the early days of the COVID crisis, with limited information available, what we saw was that many of these laws and regulations were driven by panic rather than science, evidence, and human rights. Some of the laws mirrored exactly the kinds of responses that we saw from countries in the early days of the HIV epidemic. For example, some countries enacted laws criminalizing non-compliance with self-isolation measures and COVID exposure and transmission. And we know evidence shows that criminalization or disproportionate use of criminal law drives stigma and discrimination and is indeed counterproductive to public health measures and to building community and public trust. Other countries issued overly broad decrees penalizing non-governmental reporting on COVID as misinformation or the dissemination of fake news. These laws often targeted journalists and independent news media. And something that we heard both from Alan and from Gerson, that the responses actually disproportionately, the legal responses disproportionately affected those who were already the most vulnerable. And what do I mean by that? So for example, there was stigma and discrimination of LGBT communities in some cases as being the vectors of disease. Because of lockdown provisions, sex workers not being able to practice their trade. And there are many, many stories like this. In one country, the lockdown measure is that men can go out on certain days and women can go out on other days, being totally silent on transgender populations. So transgender people, whenever they step out, get arrested. So disproportionate impact on the most vulnerable is something that is also another lesson from HIV that we see in how the law is being applied in the context of COVID. So many of the critical lessons on law and human rights from the HIV response are indeed relevant and important to reflect on for COVID-19. So for example, addressing the overly broad application of criminal law that can impede effective responses and perpetuate fear, stigma, and discrimination. Supporting governments to understand the human rights dimensions of an effective public health response, focusing very much on lawmakers, law enforcement authorities, and the judiciary. So the importance of going beyond just the medical or the public health community. And linked to that, and I think this is very central to UNDP's approach, is also supporting the important role of community leadership and civil society, and also understanding the rights dimensions of effective responses and being critical to successful epidemic responses. The importance of addressing gender dimensions of legal responses to the epidemic, including implications for sexual and gender minorities, girls, and women. Ensuring the coherence between evidence-based public health laws and other relevant laws, for example, policies around criminal law, family law, youth, development, livelihood, more broadly. So applying the lessons from COVID-19, UNDP came together with the World Health Organization, UNAIDS, the O'Neill Institute for National and Global Health Law, the International Development Law Organization, and the Interparliamentary Union to establish the COVID Law Lab, the COVID-19 Law Lab. And you can find this online if you Google COVID Law Lab. The lab tracks legal responses to COVID-19 from across the world to help countries establish and implement strong legal environments to address the pandemic. The goal of the lab is to ensure that they are promoting laws which protect the health and well-being of individuals and communities, and that these laws adhere to international human rights standards and other relevant global commitments. So far, the lab has collected 2,000 pieces of legislation and policies from 190 countries. And these are categorized or tagged across 33 themes, including access to health services, essential services, information or misinformation, procurement of health commodities, police powers, and surveillance applications and software. The COVID Law Lab promotes transparency and accountability by providing an accessible repository where official versions of COVID-19 laws and policies are publicly accessible. Many of the COVID-19 laws were subsidiary legislations and executive proclamations and orders. This exacerbated the problems of unavailability of official versions of legislation in some jurisdictions. But by providing intuitive search capabilities by themes, categories, and geographies, the lab provides governments and civil society the ability to compare legislations on particular themes and issues with those of other countries. And this helps, we feel, in driving both accountability and public trust. We're also working with a number of country partners on human rights analyses of the legal and regulatory measures adopted in response to COVID-19. This review adapts the methodology of UNDP's HIV legal environment assessments, which essentially use a rights-based approach to bring together those who are affected by the law with those who implement, shape, and enforce laws to look at what are the most effective responses for particular health outcomes. This focuses on public health surveillance and the use of digital technology, impact on most vulnerable populations, and the participation of civil society in lawmaking processes, among other critical issues. And this is in the context of COVID. The review is currently underway in a number of countries, and we're looking forward to seeing what this tells us and how we can use the outcomes of the review to shape legal responses. UNDP and UN Women are also working on a COVID-19 global gender response tracker. This is also available online. The tracker monitors policy measures by governments worldwide to tackle the COVID-19 crises and highlights the responses which have a strong integration of a gender lens. It includes national measures that are directly addressing women's economic and social security, including unpaid care work, the labor market, and violence against women. The tracker is coordinated by UNDP with substantive leadership and technical contributions from UN Women. We're also developing practical resources for addressing gender-based violence in the context of COVID-19, which is a serious, serious problem. So for example, in Bangladesh, we've supported the National Human Rights Institution to establish a hotline to receive human rights complaints. In Fiji, we're working with civil society on establishing and running civil society-led GBV counseling helplines. In Uganda, we're working with government and UN partners to adopt e-learning modules on GBV for police, public prosecutors, the judiciary, and prison officers. So our approach is very much to work with the UN family, with civil society, with communities, and with lawmakers and those who enforce the law. A lot of what we're doing is also in the context of HIV, really making sure that we can support this constellation of partners and communities of people living with HIV to help apply the lessons of community-led responses within HIV for COVID-19. And that's also, I think, really quite important work. And we're looking at how we can address stigma and discrimination in COVID-19 responses, focusing across priority settings of community, education, workplace, healthcare, justice, and humanitarian settings. So I just want to end a little bit with I think what was central to both Alan and Kirsten's presentation, and that is really supporting people on the ground who are doing the work with communities and really taking that experience and using that to shape and inform laws and the implementation of laws. And I think that's really central to the question, which is in the title of this webinar, in terms of how can we use the law to build trust, community trust, to enhance community participation, and to strengthen the accountability of lawmakers and those who implement the law. I think, you know, we often see the law as being in conflict with those. but I'd like to leave everyone with the hypothesis that actually, indeed, the law can be used as a tool for better health and as a tool to build public trust if we look at it the right way in the context of human rights, evidence, and the rights-based engagement of those who shape and implement the law and those who are affected by it. Thanks, Sophia. Look forward to the discussion.
Thanks, Mandeep, and thank you very much for the global frame, right? And for really like raising a whole range of issues that came up through the other two presentations and kind of giving us these different pieces. I'm really struck with this, what's it gonna take to bring back public trust? And what is it going to mean for the future? And it's a personal concern, but I think it's a kind of a global concern for all of us. I'll start with, and by the way, just for all of you to know, everybody's noting how fabulous these presentations are. So you should all feel good about your presentations. But so, you know, you've talked some, all of you, this is a question to all of you, about the impacts of the immediate legal and policy response to COVID, which clearly has been problematic everywhere, but particularly for some communities. And at some point, we're going to have to address the longer term recovery from this, including the compounding impacts of poverty, of job loss, the loss of education, et cetera. What do you all see as the role of law in shaping this recovery? What is the role you think of each of your institutions in helping to engage with governments and others on this issue? And it's a question to each of you. Who would like to go first?
Well, I think that's a great question. And indeed, there have been many, I would say, negative effects as a result of the measures that have been put into place. I think in the context of Kenya, we've seen increased pregnancies with children not going to school. We've increased cases of gender-based violence. We've seen increased loss of income and jobs from people both in the formal and informal settlement. And we had some measures put into place by the government in terms of tax reliefs, in terms of reduction on value-added tax on certain products, but all these measures have now been restored with a belief that we're almost going back to normal while the cases are still rising and we still haven't gotten everyone vaccinated or provided treatment. So I think the role I see organizations like KELIN playing, whether in Kenya or elsewhere, is to, one, document, as has been done by many other partners, what are some of the challenges that have happened for healthcare workers, for school-going children, for vulnerable groups, and also what have been the effects of the measures put by government, and also looking at the existing legal frameworks in various countries. Do they provide for social protection? Do they provide for socioeconomic rights? And how then do we work towards government's budgeting for whatever that was neglected during COVID? And this requires engaging with Parliament to see whether they can make allocations towards areas that may have suffered in the process. So I think the goal then becomes going back to look at what harm was caused, what is the legal framework in place, who are the players, and how do you try to engage with those players to try and restore some of the sanity? So schools may be reopening. How do you ensure that people are progressively going back to school, but in a safe manner? For those who need some elevation from debts they have taken to run businesses, in what way would government be able to step into the space and try to probably give them taxes, holiday taxes on some of the businesses they are running? And so the government has the ability to put some of these measures in place, but they need to do it from a consultative perspective and in a manner that would make sense to the different stakeholders. So I think I'll pause it there.
Thank you. Gerson, Mandeep, anything to add to that?
No, I think I agree with all those points. I feel like for me, one of the key areas is to ensure that, thinking about organization, others like ours, is to ensure that we work to have communities have an opportunity for meaningful participation in decision-making around these different outcomes. And what we've seen in the past is that sometimes, I think as happens everywhere, the larger interest, the lobbyists and everyone else comes in, and really the communities that are truly being affected by these issues don't have an opportunity for input that's meaningful. And I think another thing I would say is, in terms of the existing rules and protections, I think on our end, a lot of protections do exist for a lot of vulnerable populations, like those that are disabled, et cetera. A lot of these protections, I feel like, have been put on hold and even maybe informally put on hold during the pandemic. And I think for us as direct services providers is looking at those and ensuring that, you know, at whatever point the emergency is over, that we can actually start moving forward in a more normal way, whatever that looks like, is ensuring that those are protected and continue to be enforced.
Thanks. Mandeep?
Sophia? Yeah, thanks. And it's always great to speak after these two because I don't have to say too much except that I agree with them. But I want to pick up on a couple of things. So first of all, I think it's a great question. And I've just made a note to myself that, you know, as we talk about recovery in the UN system, we must talk about the role of law. And I think there's an important role there that we must recognize. I want to start with, I think we should think about how we use the law to build public trust, because beyond COVID, there's a broader crisis in public trust, right? So if we want to build the social contract more broadly and as part of COVID recovery, I think we need to think about how we can use the law. Part of it has to be about what can we do to address the underlying and intersectional vulnerabilities that both Alan and Gerson talked about in their presentation as well. And that will mean social protection in a way that we've never done it before. It will mean addressing the underlying issues that drive these intersecting vulnerabilities. So gender inequality, race, people who are marginalized by our societies, who are vulnerable. And I find it fascinating that, you know, in some countries, for example, Canada, north of the border from some of us, the first allocations of vaccines went to First Nations and those in nursing homes and congregate settings. And the choice on First Nations was because they were disproportionately affected by COVID. And because of the underlying vulnerabilities and the intersectionality and what that meant in terms of the impact of COVID. We need to use that logic in the recovery more broadly. And I think today, in the context of HIV, because I'm an old HIV activist, you know, I wonder where we would be if all those years ago we had decided, hey, we need to really focus on men who have sex with men, transgender people, people who use drugs, sex workers, people living with HIV. These are the most affected populations. We need to address the underlying vulnerabilities that are causing them to bear a disproportionate burden of the epidemic. We would not be at a place today where 62% of new HIV infections are in key populations. So I think we need to learn the lessons and really think about using the law to address these underlying and intersectional vulnerabilities. Gender is a huge part of that. And really, I think, look at social protection and look at human rights in an integrated way to really, really see how we can lift everybody, but by starting with a focus on those who are most marginalized and most vulnerable. Thanks.
Great, thank you. One of the questions I feel kind of moves quite nicely from there, so I'm kind of jumping around in terms of the questions that have come in, but you know, you've all highlighted the importance of community engagement in legal responses to COVID. Are there good models that any of you can speak to in ways that talk about perhaps appropriately remunerating civil society participation, overcoming potential power differentials between government and civil society actors, particularly the most marginalized, and once that's been done, whether that's led to more appropriate legal responses? And Mandeep, I'll start with you this time, since you got to go last time, I'll start with you.
Good, no, I was gonna say it's a little inappropriate to start with the UN person on this, but I think, there's a really big issue, and I said, I talked about sort of the broader crisis in public trust right now. There's a real problem in many parts of the world with a lack of funding for community responses in civil society, but also the use of restrictive measures to shrink civic space and the space that they have to operate. So I think we have a big problem, and I think we're going to have to address that broader problem of focus and funding for civic space, for civil society organizations, for community groups who are central to effective pandemic responses. We've seen it already in the context of HIV, and it's going backwards, and it's something that really needs to be looked at very seriously. The best way to build public trust is to give community-led responses the resources that are needed, and the legal and policy space that's needed for them to work, to work in the COVID response, but on health and development more broadly in communities. That's the best way to do it. I think it's efficient, it's effective. There's lots of research out there on that, but it can't be done for free, and it can't be done if you're cracking down and restricting rights of communities and vulnerable communities, especially. Thanks.
Thanks. Gerson, Alan?
I'll be the middle child and go second again. No, I totally agree with Mandeep's point. I think those are phenomenal points. I think the only thing I can add is, thinking at least in terms of trust in the judicial system. That's been an ongoing, challenge. I know across the board, but I'm thinking of us specifically, it's been an ongoing challenge. So much so that, thinking back to when we first started our project with the county and MLCP, we would have community health workers who had prior engagement with the judiciary themselves have distrust of us as nonprofit lawyers. They're like, the whole legal system, including these people that are supposed to be on my side, there's this inherent distrust of them. So I think there definitely it's going to be a very strong challenge to, and sort of a long process to undo not only whatever's happened due to COVID, but just the generational distrust of the system. I think transparency is key, and definitely funding for meaningful engagement by different agencies, and education, I think, is going to be very important.
Thank you. I'm grateful for you being the middle child. Thank you. Next time you're going to have to go first, I hate to say. Okay, Alan.
I think very valid points raised by both colleagues on the panel. And I think the starting point, and I keep telling colleagues I sound like a broken record, always relying on the HIV experience, but you will see the campaign around access to medicine, especially antiretroviral drugs, was actually driven by the fact that communities had literacy on use of drugs, communities had literacy around issues of intellectual property rights, and communities were then supported to be able to engage with different stakeholders to broker negotiations around how would it be possible to try and get medicines to people quickly. There are good examples in Brazil, there are good examples in South Africa, there are good examples in India, there are good examples in Kenya around, and many other countries across the world around how investing in communities drove the increase in terms of availability of antiretroviral medicine across the world. And so I think what is most important is to be able to find an avenue to provide information, and whether you're in the UN, whether you're government, whether you're a donor, in what way is your support going towards making the affected community be in a position to advocate for them? What kind of support do you need to be able to give them so that you're not coming as a savior, but you're coming as an enabler to say, we can do this together. I will either provide this information and work with you towards your legal case because I may have the legal expertise. So I think that's the relationship we want to build, but this can only happen in an environment where there's political will, where there are no laws cracking down on where funding is coming from, particularly from specific funders who are seen to promote human rights, where we don't have authoritarian governments that do not want to be questioned around the way they are treating their citizens. And so political will, civic space is critical in terms of creating a model that allows communities to feel that they can indeed question based on the information they have received, and also be part of a process of trying to shape their destiny and career and lives within the response for COVID. So building the trust of the community is extremely effective, and I think that's one lesson many governments are learning late in terms of the COVID response, that when you have your public health messages coming from the top of MOH and not from the community groups on the ground, the uptake is quite different. And again, as Mandeep said, the commensurate payment of what you're paying at MOH and what you're paying the community health volunteer are quite disproportionate, but yet the larger work is happening on the ground. So we must then see how do we reverse that and actually appreciate the community groups for what they're doing on the ground. Over.
Thank you. Thanks. And I think for the sake of time, I'm going to give a round of questions. So there's some really wonderful questions rolling in. So I'm just going to give a couple of them and then ask each of you to respond to the ones that feel most appropriate to you. So the first question is, why do you think so many governments are unable to realize that beating or shooting citizens for breaking laws meant to protect public health is counterproductive to public health? That's kind of the big question we can all take. And then there's a question about the technology divide and the extent to which that is hampering access to health and potentially to information about the vaccine, and the extent to which the technology divide is important. It's Mandeep, something you raised earlier, but it's related to each of our communities. And then I will read one more specific question, Gerson, which is directed to you, which is from someone who works in trauma-informed legal advocacy for trafficking victims, who's very interested in that legal prescription pad that you mentioned, and asked if you could say a bit more about what such a thing would look like and such a multifaceted approach to client care. What do you highlight when collaborating as a lawyer with medical professionals, and how do we build capacity and conduct training? So we'll take a round on those, and then we'll do one more round if we can. Gerson, the floor is yours.
Yeah. So yeah, it sounds like that third question is really calling my name, literally. So yeah, so the legal prescription pad, it's a the document itself is fairly small, and it really looks like a prescription pad, and there's essentially, I think it's like 10 categories that we've already engaged with the providers and whoever's looking at this on, of areas that we can help, whether it's healthcare access, income stability, intimate partner violence, immigration, or other areas of work. And the goal behind it, as I mentioned, is to really have like a very quick reference guide for the person that's meeting with the patient to say, look, these are the areas that I know that our legal team can intervene in. Here's this prescription, take it with you. And when you talk to them, engage with them on these issues. That's the easy part, right? I think the challenging part, as you mentioned, is how we engage and collaborate with medical professionals. And I think for me, one of the most challenging aspects of that has been the funding aspect. I think a lot of, even once you get, medical professionals to see the value of what you do in terms of, offering patients additional supportive services, how is that funded? Because I think to have that partnership be something that's meaningful, I'm thinking, let's say a large county clinic or a large, city clinic or hospital, you're going to have so many patients, so many providers, sometimes, potentially hundreds of providers, unless you have someone on the legal side who's really invested on that particular site and is meeting with various people within leadership on the ground, engaging with them through trainings, engaging with them just one-on-one, they're not going to really appreciate and understand where that comes from, what the value of the legal services are, and why they should invest time in screening for these things. And I think for me, like the biggest challenge, and I think what I've learned so far has been that, and thinking of it in terms of the healthcare system, they are primarily interested in what's going to be their return on investment. So they're putting in $100,000 for a lawyer. What does that mean for them? And for us, as legal services providers, we're definitely have been behind other colleagues in, say, public health and even the healthcare sector in terms of collecting data. But we've definitely started improving on that. So now we can say, look, this year we've seen, 30 patients who we were able to establish public insurance for. These were patients that previously you were paying the bill for. Now there's $300,000 for this patient and $200,000 for this patient. That's the return. And I think in areas like that, when we try to put it in terms of financial return on investment, and it's, I think, what the administrators really care about. And then also sort of what's the societal community return on investment. Obviously having someone who's housed, someone who's stable, not homeless, has access to care, has a lot of benefit to the community as well, particularly at a time during a pandemic when access to care and stability is so important. So I'm more than happy to also talk offline, but I think just definitely looking at and also finding a champion, one person, one provider who understands and who can then kind of infect, since we're talking about pandemic here, infect their colleagues with the idea that, working with lawyers is something that's key and beneficial. And if I could say very quickly on the technology divide piece, that's something that, we're seeing so much of, particularly in our communities, who I think need the most education, who have the most apprehension around the getting the vaccine. For those few that actually want to get it, the systems to get it are very convoluted. Here in Los Angeles, there's a statewide website and a county website people can log on to. Most of the time you log on, there are no vaccines available, no appointments available. There's a phone number that's open that people I've heard have waited 3-4 hours on hold and haven't been able to get through. So definitely a lot of challenges there as well.
Thank you. Thank you for that. Mandeep.
Yeah, I mean, I want to talk about the digital question, and I think it's a really interesting question. I mean, I think, yes, there's a huge digital divide, and what that means is that it's the voices who have the digital tools that their voices are heard at the, and others are not. And I think that's something that absolutely needs to be addressed. The fascinating thing, of course, about COVID is that it's really accelerated this trend of using digital tools for access to services, everything from basic government functions to providing health and other services. The worry, of course, is, and I think it's great because I've seen it in our work at UNDP. We're able to reach vulnerable, marginalized populations with safe, in a safe way using digital tools. We're able to, there's, financial inclusion is strengthened through the use of digital tools. There's lots of really good uses. The worry, of course, is how that data is being protected, the privacy and confidentiality and protection of the data, and that digital tools and the data that's generated in the use of digital is not used to target in a negative way populations that are criminalized or marginalized in other ways. And Alan can speak to that certainly from experience in Kenya as well. So like most things in life, it's potentially a very useful tool, but needs to be handled, managed, regulated carefully. I think the big area in terms of recovery, which will be really, really critical, are both around rebuilding public trust, the social contract. It will also be around social protection and how do we lift really vulnerable communities. And something that was implicit in both Alan and Gerson's presentation, which I think we should think more about, is, what are the new kinds of partnerships and collaborations that we can bring? I mean, it wasn't evident before that medical and legal people would work in the same facility. What Gerson's doing is super exciting, that the lawyers are there or the paralegals are there in a health facility. Are there interesting innovations like that, which can help us to really rebuild trust and really, strengthen human rights-based responses to pandemics? And I think there's some interesting things to think about there. There's a great question on Syracuse principles in there that I hope that we can respond to by email.
We're getting to it.
Okay, good. I was like, I don't want you to miss that because that's a very good question. Over to Alan.
So I'll deal with the question around the governments not being able to realize that certain measures are counterproductive in terms of our public health approaches. And I think the quick response to that, again, is collecting evidence. I know, again, under the leadership of UNDP and Mandeep's team, there was a great publication called Global Commission on HIV and the Law, a report that sort of, and I know, Sophia, you also worked on it a lot, but that particular report was able to pick up the good and some of the not so good practices in terms of demonstrating how counterproductive it is not to provide condoms to people in a prison, or how counterproductive it is to arrest sex workers when you find them carrying lubricants and condoms in terms of the HIV response. And so I think continued documentation of how counterproductive some of these measures are in terms of defeating the actual goal, as I gave the example of the fact that you're trying to get people to be home by 7 o'clock, but the way you're enforcing the law is actually putting them more at a risk of getting COVID, which is defeating what you're doing. And so some of this evidence, some of these discussions need to be brought forth to these government officials for them to be able to appreciate why then do we need to change our approach. But again, having learned from the experience around the HIV response, we can't avoid to work with the law enforcement officers. We can't avoid to work with the judicial officers. Those who are actually enforcing those particular laws and policies need to get onto a table and have conversations with different partners, be it community, civil society, the UN family, or their fellow peers from different countries who have already seen the light and know that this is counterproductive. That would be one way to be able to go about it. So I think I'll stop there so that we can have time for the Siracusa principles, but I think on the digital technologies, again, it can be for good or bad. And I think the main point here is that we're not saying that everything should be absolute in terms of human rights in a pandemic. There are limitations that are allowed, but the question becomes, how are you going about limiting those rights? Are you doing it in a way that is affecting people's lives, or are you doing it in a way that is making it safer for people? We understand there are trade-offs too. Not really trade-offs, but there are times your rights have to be limited, but it has to follow a due process. So that's been the approach towards the digital technologies. There's definitely a divide, but it depends on how different governments and different stakeholders drive that particular agenda. Is it to their own benefit and to the detriment of the community, or is it something that will make access to vaccines, access to testing facilities much more easier for everyone? Over to you, Sophia.
Thanks. I'm going to do one more round of questions in terms of the order, and I'll start with the one about the Siracusa principles, which is essentially how can actors come together to develop COVID-specific human rights principles on the necessity and proportionality of public health measures. But I want to add two more specific questions to this in the round so that we can go. And one of them is specifically around legal and policy efforts surrounding mental health access, because there's elevated depression and anxiety throughout the pandemic. And basically, how is the legal system addressing this? And then the third, also more specific, is that the law is often used to define trans people out of existence. At the same time, most existing health surveillance systems don't adequately capture SOGI data, regardless of the legal environment. This then means that we've got no confident estimates about how big the trans communities are in any given country or area. What can be done to advocate for marginalized communities like trans people when lawmakers and policymakers argue that trans people don't exist or aren't a big enough group to deserve special protections and rights, or are otherwise undeserving because of being undocumented, mentally ill, or whatever the case may be? How can the law help in this area? So I'm taking that as the last round of questions for each of you. Who would like to go first?
I'll start first because I think it'll be good to end with people who are actually doing this work on the ground, Gerson and Alan. So I think the Siracusa principle discussion is really interesting. And I think Alan picked it up in his last intervention. You know, we need to look at what is the public health objective you're trying to achieve, and what is the least restrictive measure which is actually going to get you there. And there needs to be due process, and it needs to be embedded in law. So you can't do something that's illegal in that vein. So I think the principles are there. I fear to say that a lot of people don't know about the principles, and a lot of people don't know that that's what they should be doing, is applying this. And we've got experience in applying this. And I think maybe it's something which should be popularized a little bit more as a tool. I do think there's a real role in collecting and sharing evidence of how and when rights are restricted for public health measures, and sharing that, because I agree with Alan. I mean, one of the things that we've seen in the follow-up to the recommendations of the Global Commission on HIV and the law is that it's often the most persuasive for a government to see and to learn from what other governments are doing. So I think sharing the good practice and also sharing the impact of the bad practice with amongst peers is a good way of doing that. And I'll end on the trans question. I mean, I think the dearth of data on sexual orientation and gender identity is a big problem. And we need more. And it's kind of it's kind of a vicious cycle, because if you're criminalized, if you're marginalized, if you're made to feel invisible by society, then it becomes difficult to collect data on these populations. But there are ways to do it. And I feel like collecting that data is really, really critical to driving investments in the kinds of services and responses that you need for the most marginalized populations. And I think one of the best things that people like I can do at the UN, or that you can do in academic settings, is to give platforms and spaces for people from these communities to share their experience and tell their stories, and to create that kind of space for them to share their stories, so that we have the beginnings of data. And collecting data, I think, is really important on basically what I call the development dimensions of people's lives. So we do have some data on the number of trans deaths every year, but what we need is data on access to services, health indicators, personal and security. So I think we need to look at perhaps using the SDGs as a framework, and I'm making a plug for a paper that UNDP published a few years ago on looking at the Sustainable Development Goals, and how those, what data we have across the various Sustainable Development Goals for people of different sexual orientation and gender identity. And I think that's kind of the beginning of where we need to go. But I fully agree. I mean, I think we need, it's a big challenge. We need much more data on transgender people and other marginalized communities in order to get the right policy and legal responses. I'll stop there. Thanks.
Thank you. Alan?
I will take up the role of the middle child as we conclude. And I think I'll start off by saying that it's indeed important, and COVID, to some extent, has served as a reminder to people about the existence of the Syracuse principles. And I think it provides an avenue to continue building up on these at different levels, whether it's at the committee dealing with economic, social, and cultural rights, to look at it again and see what other improvements can be done on it, whether it includes those of us who are already using it in courts for litigation, for courts to be able to expand the thinking around it in the context of COVID. I think it's an opportunity to keep the discussion going around using least restrictive measures within the confines of the law, which also just mirrors around what many constitutions have around what do you take into account when you're trying to limit a person's rights. So I definitely agree with the thought that we definitely need to have more conversation around it. I think the efforts around mental health are critical. I think for those already who had mental health challenges before the COVID pandemic, and access to mental health services, especially in countries like ours, which are not easily available to everyone, remains quite a challenge. And also the pandemic itself has brought its own challenges. We've had clients who we're representing in court who have complained around the trauma they have faced in quarantine centers, being taken to a place that is not extremely hygienic to what you're used to, being confined for more than the required number of days. And these are some of the arguments we brought before court to say, indeed, has this violated a person's right to health, including aspects of mental health. And so I think it's important that this is nuanced, and for those who then need access to those services is important. I think I'd emphasize the point Mandeep made, that what COVID has done is to unearth all the underlying determinants of health that really need to be spruced up. And so if any government or any development partner or any donor is keen in terms of getting people back on track towards having an almost normal life, then we really need to speak through around how we're trying to address those underlying determinants of health that have forever been neglected, but now have come out glaring as a result of the COVID pandemic, that without food, without water, without good housing, without good education, without good social protection, any pandemic will strike you down, and the earlier you make the investments, the much better. And I think on the last point around transgender people, I think I would fully echo the points by Mandeep in terms of, for those who have an opportunity and space to get them where they can speak to the decision makers, where they can be able to use innovative tools to collect data and present their challenges within the context of this pandemic or access to any other services. I think it's critical to give them that visibility and platform and get them into spaces where this can be raised. So I think I'll pause there.
Thank you. Gerson, the last word.
Yeah, I know that we're up on time, so I'll focus primarily on the mental health question. I think for me, looking at how we can really look to improve screening tools, I think we're fortunate here in Los Angeles that there are mental health services, for the most part, readily available for most people that seek them. However, we often deal with clients, for example, that, not being mental health professionals ourselves, but we see that there likely is some type of underlying undiagnosed mental health impairment that the patient is facing or client is facing. However, they just haven't been screened or haven't, actually sought help. So looking at screening tools and looking beyond, the healthcare provider, but looking at like different places where those can be housed and how those services can be provided. And I think one big piece related to mental health too is sort of the vicarious trauma that I think a lot of the helpers have had during this time, right? Our healthcare providers, our supportive services providers, legal teams, everyone else really kind of in ourselves going through the trauma of the pandemic and losing loved ones and everything else that involves that. Plus looking at our clients that are facing these, catastrophic failures of our supportive health systems, also figuring out how we can ensure that our people that are in that position to support these communities are also themselves able to meaningfully access mental health services is important.
Thank you. And thank you to all the panelists for this incredibly stimulating event. I guess with that, I need to close. I feel like there's so much more we could talk about, but let me just close by thanking all of you for attending, for the wonderful and provocative questions, to the folks on the IIGH team who work behind the scenes to make this happen, but really, truly, Mandeep, Alan, Gerson, thank you for this amazing, informative, and I think important exploration of this COVID law and human rights nexus. And I'm really grateful that you put front and center the issues that we have to consider. And I really hope that we can be thinking kind of collectively about what it's going to take to build public trust and rebuild public trust to move us towards a more just post-pandemic world. So with that, thank you everyone and take good care.